and our first of 3 webinars focused on the opioid epidemic. California Improvement Network, for those who aren't familiar, is a community where you can learn and share better ideas for care deliveries. We offer webinars, trainings, and action groups, which are small mini collaboratives working on one particular project. We will be soon offering an action group for residency clinics working on safe prescribing, so if you are interested in that, please make sure you're on our mailing list. So this is the first of 3 webinars on how to manage the opioid epidemic and try to save lives and decrease addiction and morbidity from what we've seen in California and nationwide over the last several years. The first one today is you'll hear from 2 leaders in community clinics and how they changed the culture within that clinic to make sure it was patient-centered and safe and helped with a team approach, and I'll tell you a little bit more about the speakers in a minute. On May 20th, we have 2 health plans from California and Oregon, which will talk about how an innovative visionary health plan approaches the opioid epidemic. This will actually be interesting to a broad audience, not just if you work at a health plan, because it'll be focusing on their community approach and how they needed to involve the whole community to make a difference. And then on June 4th, we'll have 2 primary care residency leaders, which will talk about their own journey on trying to change the culture within a training site. So recognizing that the opioid epidemic has become such a significant problem, we'll be reaching out to you as we develop initiatives in the 3 areas that were identified as priority by the Obama administration in their announcement just a few weeks ago. On the first, supporting safe prescribing practices. The second, expanding access to medication-assisted treatment. Because there's lots of concern if we cut down on unsafe prescribing without offering people resources to treat addiction in an evidence-based way, we're going to save prescription deaths only to increase heroin deaths. So we're thinking a lot about the problem we have in California with lack of adequate access to Suboxone, methadone, and other addiction treatments. And finally, the third pillar is spreading naloxone in the community, both education and overdose prevention. So please go to our website, look at CAN, and sign up our mailing list if you're interested in learning more. A few logistics I want to go through about this webinar. We will record the session, so if you have colleagues who are interested or you want to hear it again, it will be on our website within a week. You'll also see other webinars in our library. We're going to have a large group today, so we're going to be managing questions through a chat button. If you look on your screen, on the upper right-hand corner, you'll see a little bright blue button. If you click on that, it turns on the chat function. We ask you if you have problems or logistic questions, if you could just chat the host. But if you have questions for the speakers, please chat to all, and that way everyone can see the question. We'll be going through the presentations. First, Dr. Nurit Licht for 20 minutes, and then Dr. Rachel Solotaraff for 20 minutes, and then we'll open up for questions. These folks have such a wealth of resources, and we anticipated there'd be a lot of questions. So we're actually going to extend the normal webinar. Typically, it's only an hour, but we'll keep the lines open until 1 o'clock in case there's a lot of questions. So now I'm delighted to make our introductions. You'll first hear from Dr. Nurit Licht. She's a full-spectrum family doctor and the Chief Medical Officer at Petaluma Health Center, which is a community health center in Sonoma County that serves 23,000 patients. As a physician, she provides care to a panel of patients in the health center, the hospital, and a skilled nursing facility. In her leadership role, she focuses on care innovations, especially related to expanding care, team roles, groups and wellness, and technology in the health center. And then you'll hear from Dr. Rachel Solotaraff. She's the Chief Medical Officer at Central City Concern, which is a large organization focused on health care to the homeless, along with direct access to housing and focusing on peer relationships and helping people get benefits. A very comprehensive program in Portland, Oregon. She also serves as an internist and a board-certified addiction specialist at Central City Concern's Old Town Clinic, which is a health care for the homeless program. And there's a clinical focus there that you'll hear about, focusing on the mix of chronic pain and substance use disorders. And she also, with her leadership work, is focusing on innovation and clinical and financial models to support integrated care. So I'm going to turn it over to Dr. Licht.
Thank you. Thank you so much for having me. So I'm going to give a short presentation about the work that we've done at the Petaluma Health Center related to management of chronic pain. And I always like to start with the take-home points. of what I think are successful in terms of kind of managing chronic pain in a patient population. We now have 23,000 patients, but like I'll tell you, we had a lot fewer when we started this process. So number one is to adhere to an accepted policy that promotes the highest standard of care. And as standards of care obviously change, you can advance the policy to kind of what is the new accepted policy around it and make sure there's consensus within the provider group as well as the staff. Number two is to expand the care team that provides care management for these patients, and I think that that's a crucial function. It's very hard when this all falls on the shoulders of the provider in the room with the patient. And number three is to utilize quality improvement methods to expand the capacity and decision-making of that team. We don't want patients that are just jumping through hoops and getting back to the primary care provider. We actually want the team to feel really empowered to help make decisions for that patient that are going to be the best. And so we are Petaluma Health Center. We're in southern Sonoma County. We have about 23,000 patients. And what makes us tick is quality improvement, the patient-centered medical home, and team-based health care. Sonoma County has its problem as well with drug poisoning death rates, and we have a large opioid epidemic going on here too. We actually have a community health initiative that is starting now to really look at it broadly based, and it's centered in community health centers, private practices, hospitals, dental offices, specialists, and the community at large. So step one we're going to talk about is policy. So I'm going to take you back to our journey, which started about 10 years ago. And at the time, Petaluma Health Center was much smaller. We only had 12,000 patients. We had about 400 patients on chronic opioids. We used paper charts. We didn't have an electronic medical record. We had not the greatest system to access to care. Our care team model was young. It was a provider MA teamlet, and we really just had a few groups in place for a wellness and groups program. And the reason I put this up here is because I think that regardless of where you're at in your health center, in your practice, you can still have a policy. And the interesting thing with pain management is that you tend to get a lot of consensus around it. And that's exactly what happened for us. We had high agreement about the need for change. We had multiple meetings where everyone was really had easy consensus to say, you know, we really need to do something about this, and let's go ahead and do it. Everyone wanted to adhere, and even in the first year we had 45 patients that were taken off opioids. We made the policy kind of in advance of where we were at the time. We knew that we wanted to have a large team that could help with this, and we didn't have the team yet, but we knew that we could grow that over time. So I put here kind of what I think are keys to a successful policy in terms of how is it patient-centered, and that's on the left-hand side. And on the right side, I put what we thought were the key elements that we really needed to make sure that we had in the policy. And so how do we deal with new patients, and what's our stepwise treatment plan, and what are contraindications, what's the appointment process, peer review and case review, and then we did actually have 3 doctors who obtained Suboxone licenses at the time, and how would we kind of play that in over time. We used to share our policy, but I actually think that the best current policy is really with Oregon Pain Guidance, and I put it in here. It's lovely, beautiful, has colors, and it really has all of the information that's really necessary for success. So the next part is the exciting work that we did over the next 10 years, actually, which was really expanding the team. For us, care team expansion happened for all of our chronic care conditions, and so we were able to apply it as well to chronic pain management. And one of the biggest things that our nurses did was a very important phone screening procedure for new patients, and that really allowed our patients to understand who were coming into the practice who had chronic pain, where were we at? And it also got the provider all the information that they needed. They really did tell the patients that there was really no guarantee of any prescription at the first visit, that we were really going to follow our clinic's guidelines in terms of how we manage chronic pain. And I think the patients had a good understanding of that. We also got all their records and a patient activity report and all those things ready to go. The next is the medical assistant, and our medical assistants are very, very active and empowered, and it's one of the most lovely things, because a lot of the things around chronic pain management that are so important to get done are things that sometimes in light of time pressures that the providers have, are actually quite difficult to do. And so these are all the things that the medical assistant is making sure happens during a patient appointment. So the urine drug screen and medication agreement and all these things being up to date. The provider just needs to say yes. And so that actually makes it a lot easier for them to have the information when they go in to see the patient. In addition to that, we have integrated behavioral health, and we have a psychologist who actually has done a lot of work around chronic pain, and we were able to offer patients IBH appointment for evaluation unless they were already in care. And that makes a big difference, because I think to say that pain management should be independent of behavioral health or mental health services is maybe not a good thing to say. And so we really do offer those appointments to all of those patients, and we also talk about smoking cessation with them. And then during that time also, in the past 10 years, we had a really significant growth of our groups and wellness and ancillary services. And so having pain management education with a shared medical visit with a standardized curriculum, peer support and shared medical visits. We have the availability for physical therapy referrals, and then started a back class here in-house, nutrition services, integrative medicine consultation, acupuncture, and we have a community fitness program. All of those things give the alternatives to opioids for the patients, and that's really important. This is a integrative medicine acupuncture. This is kind of one of our group classes that you can see how we do that. We do group acupuncture, which is exciting. This is our chronic pain, living with chronic pain. This is an education type visit, and it's not just focused on medications, although harm reduction and medication education is a big part of it. It also has a lot of integrative medicine focus and a lot of behavioral health focus. And so this is a really effective tool for treating patients with chronic pain. In addition, managing depression and anxiety is a very important piece of this, and we have both groups and individual treatments available to patients, and that helps as well. So having all of those things in place really makes it a lot easier on the provider because the team feels like it's much bigger. They're not in it alone. There's other resources for their patients, and there's guidelines about what we're doing. But the next step, which is step 3, is kind of where I like to really focus in on, because I think that this is where it really gets exciting. One of the things that we've worked a lot on is using quality improvement and data to kind of get that, expand the decision-making beyond the team. And we've done it in a lot of areas, and we're moving towards doing it in chronic pain as well. So now we're fast-forwarding to 2015. And teams and providers are receiving routine reports about their comparative performance. So what can we give to providers that is helpful to them? Well, we can give them patient-specific, actionable data. Who are their chronic pain patients? What are the missing elements that those patients might have? Who are their patients who are on a dangerous combination of medications? Or who are their patients who are on a very high dose, over 120 morphine equivalent doses, and so on? So we can give them that information and then say, how can we help you to improve this? We can also see what providers are suffering more than other providers to kind of give them more of a resource, or to try a quality improvement cycle, a PDSA cycle, to assist them with their patients. We can also give team-based actionable data, and so that focuses on the medical assistant, the nurse, other people in the team who are doing things for us to make sure that we take good care of the patients. Metric definition, we can define what is it that we really want to follow. Some of those things are mandated to us from the outside for other QI measures, but what is it that we really want to follow with chronic pain, for example? And then we can use data analysis to measure our successes in different kinds of trials of action that we do. So this slide here is from a recent presentation that we did for providers, and this looks at kind of actionable data. And this was actually, we were relatively pleased with this with this data here because it showed that these patients who have chronic pain, who actually come in quite a bit, are doing pretty well in terms of their cervical cancer screening, breast cancer screening, colon cancer screening, and actually 56% of them have a complete advance directive on file. So this allows the providers to see, okay, you are doing those other things that we're wanting to do with these patients, so it's a really nice way to bring actionable data, and we can drill that down to provider and to patient as well. This next slide talks about the multidisciplinary review team that supports the PCP with objective case review and decision. So we started this team being either an associate medical director or the medical director with a mental health provider. And we kind of did it on a consultative basis, saying, okay, if you're having a problem with one of your patients, come on in and let us help you with this patient, make a plan. And we've tried to actually move that forward. It's now becoming a very robust team with a doc, a nurse, a pharmacist, mental health provider, all who have gone through the UC Davis Project ECHO training, and they're setting up a review process that's independent of referral. So really looking at our high-dose patients and just starting to go through them one by one and getting the primary care provider involved, but helping them to kind of get through what are we going to do for this patient and how can we improve our care and reduce harm for this patient. So kind of taking that, expanding that decision-making capability to not make the primary care providers feel like, you know, there's an epidemic and you alone need to do something for this group of patients that you have, is really going to take some of the burden away and help us do it as a team. We have a new call to action here at our health center because I think for many years we felt like we were doing a very good job with pain management and we were doing okay. And I think that that was kind of evidenced by the fact that we actually didn't have a large increase of chronic pain patients on opioids despite having doubled our size since 2005, which means that our new patient procedure was going quite well. But there really is an external call to action, which is also influencing us. And so our managed Medi-Cal is requiring authorization requests, requiring weaning plans, removing high-risk medications from the formulary, and really trying to move kind of chronic pain management into a quality-based incentive program. And that's great for us because that allows us to move forward to the next step that we've wanted to for a long time. In addition, we're part of an ACO, and ACO really shows us what is the cost that's going on with these patients. We actually have a lot of disabled Medicare population, and many of those patients have chronic pain and are on opioids. So that's another way that we can kind of get information about what's really happening with these patients from a regional perspective, from a cost data and quality data perspective, and start to make changes together. This is from a recent presentation. This was a recent provider meeting, and this call to action is difficult. And so we kind of presented this data to our providers and said, okay, let's turn this into a brainstorming session using innovation techniques. What's the new consensus that we can build about what we need to do to reduce harm for these patients? And this was a very actionable piece of data to give to the providers because many of these things, if not all, are actually done by their medical assistants. So we were able to say, just say yes to this and all these things will happen. So this is safe prescribing practices, and just take a look at this, say yes, and we know that it will improve. And these metrics have already improved since the provider meeting. So I think when I'm looking back the last 10 years, I think what's the overall impact of this initiative? Well, I think we do have safer and more consistent prescribing practices, and that's been very important. I think at this point we have very much improved patient data, documentation, and decision support in the electronic medical record, and I think that that makes a huge difference in terms of quality improvement for these patients. We also have enhanced care via expanded team member roles, and that's been consistent throughout. The team accountability through panel management and comparative data has been wonderful for us in all of our chronic care conditions and pain management as well. We did have a lot of provider and staff turnover back in 2005 before we started this, and we certainly have less of that. And we have increased provider confidence. Just knowing throughout this 10-year period of time that we're working on this, that it's kind of never over, but that we continue to see what is it that we need to do and kind of get the consensus and move forward is very important. And we have had improved patient satisfaction as well. I think that, you know, in difficult areas of medicine, like the management of pain, it's really an ongoing work process, and we need to always look at kind of what are the highest standards of care, how do we reduce harm, how do we look at the next steps, and then continue to call to action throughout the years. I think it's likely a never-ending process of improvement, and so putting it in that QI lens really makes a big difference. So thank you.
Great. Oh.
Great. So Rachel, do you want to launch in?
Sounds great. Thanks. So thanks also for having me here. To the next slide here. And I'm up in Portland, Oregon, and I'm the Chief Medical Officer for an organization called Central City Concern, which I'll tell you all a little bit about. And this is about what we call a recovery-oriented pain management program for primarily homeless individuals. So what I'd like to tell you about today is briefly introduce what we saw as the opioid crisis in our community and in our clinic, and then our process as a clinic to understand and address this epidemic and some of the lessons that we've learned from that. So first, a little bit of background. We're an unusual organization, and so some of the resources that we have available are predicated on our history. We're not exactly a healthcare organization. We're a broad-based social service organization whose mission is to provide comprehensive solutions to ending homelessness and achieving self-sufficiency. And to that end, we really have a broad continuum of integrated services, the earliest of which was housing. We have about 1,600 units of housing. We do a lot of addictions treatment, mental health services, both integrated with primary care and specialty mental health, recovery support with peers, employment services, and then primary care as well. So this is our primary care clinic. It's called the Old Town Clinic. And we are a designated healthcare for the homeless clinic, relatively small, only about 4,500 patients, but fairly high utilizing group with a rapidly falling uninsured rate. But everybody is at 100% of the federal poverty level or below, and most folks are homelessness. And just, I didn't want to list all of the demographics, but to give you a sense, about 30% of our population has an alcohol use disorder, 20% has an opioid use disorder, 25% have PTSD, 20% have schizophrenia or schizoaffective disorder. And so to that end, we've tried to build a care model that can really address those needs. We have primarily internal medicine physicians with very robust behavioral health, pharmacy, and occupational therapy, which I'll tell you a bit about in a second. Also, because we've been an addictions treatment center for so long, we have a number of naturopaths and acupuncturists who actually predate primary care. And a lot of our resources are come from that complementary medicine relationship, which is long-standing. But also from academic partnerships with the Department of Internal Medicine at OHSU, as well as pharmacy, PsycNP, and occupational therapy partnerships. So some of this seems resource rich, some of it's because we're able to build on academic partnerships in our community. So the bad news, and similar to what Nurit showed, we have mounting rates of not just of drug poisoning, but of prescription opioid of deaths from prescription opioids over the last, these data are kind of old from 2011, but over the last 15 years. And what predicates that is that we have growing opioid misuse in Oregon. In 2008, we were the 5th highest state for non-medical use of prescription painkillers, and then in 2013, we did it. We became the highest state for non-medical use of prescription opioids in the country, with some pretty staggering statistics. And what really started to get our attention is that our heroin overdose rate in our state, which we thought had reached a high during the heroin epidemic in the late 90s, actually was superseded in 2011 and then again in 2012. That's the blue bar there. And in 2012, we reached 147 heroin deaths, which was really unprecedented in our state. And there are lots of compelling data. I don't think it's any question anymore that as people become increasingly addicted to prescription opioids, the need for less expensive and more rapid access to opioids leads to heroin use. And so we are clearly seeing the sequelae of that in our state. So sitting in the middle of this is our little healthcare for the homeless clinic downtown. And we sort of looked at our work in 3 ways, starting initially with some clinical guidelines, and then really segmenting the population and attaching programs and interventions for each of those segments, and then hardwiring that how we deliver those services into our clinic system. So this is what we were seeing, again, not unlike a lot that Nurit was describing. So this is probably around 2008 or so. But that the providers were frustrated knowing that they were prescribing medications which lacked evidence and had high risks. There were adversarial relationships with patients, thinking that, I think stereotyping patients as saying a pill is going to solve everything when it's not. A frustration, again, by providers that patients weren't engaging with all the modalities of pain management. It was clogging up our system. We were having fatalities with calls from the medical examiner about overdoses. And also, I think what was really frustrating is we didn't exactly have a policy, but pretty much when someone had a quote-unquote dirty urine drug screen, we told them, well, you messed up and you're being discharged from your opioid therapy. The person would then usually leave the clinic, go somewhere else, and the problem would start all over again. At the same time, our support staff were really struggling with capacity issues around phone calls, walk-ins for refills, and then trying to manage behavioral issues both on the phone or in the waiting room or in the exam room when patients weren't getting the opioids that they wanted. And in short, we were all just butting heads with one another. So our first step, we did 2 things early on. The first is we established what we call our Controlled Substances Review Committee, because we send all controlled substances to be reviewed to that committee, not just opioids, but stimulants and benzodiazepines as well. And I'll tell you a little bit more about that when we get to our workflows. But initially what the CSRC did is reviews all episodes of misuse or misconduct. We also review all new starts. Any patient who's wishing to start chronic opioid therapy is reviewed by the CSRC, but also if there are just complex pain management and addiction issues, it's referred to that committee. And who sits on that committee is our occupational therapist, our psychiatric medical director, who's a psych nurse practitioner, a certified alcohol and drug counselor, and one of our medical directors. There's 3 of us who rotate, all of whom are board certified in addiction medicine. And the other thing we did early on was to initiate prescribing guidelines and I list some of the items there, and what eventually were added in there as well were our opioid dosing limits, which we added in 2011. And then we had a lot of these non-pharmacologic ways to treat pain and to treat addictions, but we hadn't really looked at what's the best evidence to treat chronic pain. And also, is there any evidence of how to simultaneously treat pain and substance use disorder? So we started to do more literature reviews and try to standardize our approach to what we provide for patients with chronic pain in a non-pharmacologic realm. So some of the strongest evidence is for both physical therapy and occupational therapy, so offering those here. Providing acupuncture as well, which has a good evidence base. In behavioral health specifically, cognitive behavioral therapy and acceptance and commitment therapy are good not only for management of pain in and of themselves, but also for readiness for treatment for other things like physical therapy and physical rehabilitation in general. The other thing we wanted to do, again, that frustration with no recourse for a dirty urine drug screen was to say, okay, can we address chronic pain and substance use disorders concurrently? We pretend all the time that one of those doesn't exist, and then when it rears its head, we act surprised and upset and discharge the patient from opioids. So we actually developed with one of our alcohol and drug counselors, who's in that picture, an integrated chronic pain and addictions program, which he titled Hot Sauce. It's a 12-week level 1 A&D program that happens within the primary care clinic and focuses on a lot of things that you traditionally find in alcohol and drug program, like triggers, relapse prevention, but also things that have more to do with pain management, using alternative pain management modalities, and specifically how to communicate effectively with the primary care physician, and then or primary care provider. And then in the last 2 or 3 years, we started integrating the use of buprenorphine into our hot sauce program. So here, I just want to give you guys a sense of how we then started to try to make sense of this large chronic pain population. We actually have to, at our clinic, cap our provider panels around patients with chronic pain because we're a pretty sought-after site for it. So we cap that at about 35% of the provider panel, which is still large. And so we needed a thoughtful way to segment the population. So similar to any disease management model, let's say diabetes, everybody's not the same. There's some people who may be down at the bottom of the risk pyramid. Let's say it's diabetes, whose A1C is well controlled. They aren't having any, exacerbations of high or low blood sugar. They don't have any major complications. You can just see them every 3 months. And then there are going to be people who are at the other end of the spectrum with lots of complications, lots of risk, lots of hospitalizations. So that's more or less what we tried to think about in terms of segmenting our population around people with chronic pain. So who we think of as people being in that level 1 or low risk category are people who have low addiction risk. They have good self-management skills around their pain. They have good support and good function and activity. And those folks don't need a lot more support. And we don't need to put additional resources there. They can see their primary care provider every 2 or 3 months for check-in, but they can graduate or they can be moved up in risk levels if needed. So the second group, for lack of a better term, we call them level 2, are folks who also have low addiction risk, but they don't have a lot of motivation or engagement or insight or just, frankly, quality of life around their chronic pain. So they have low self-management skills. They have low social supports in order to be able to accomplish their own goals, and their function and their activity is low. So to meet the needs of those people, we designed a group visit model that we call Renew, which is run by our occupational therapist and covers a range of topics, some of which are medication focused, some of which are rehabilitation focused, and some are mindfulness focused. And those group visits happen monthly with the OT and the primary care provider present for the visit. And then there's also, for folks at this level, they get a behavioral health assessment and treatment from either one of our psych NPs or our licensed clinical social workers or both. And then finally, there's people who are at the highest level of risk. So they're those people who maybe were in recovery from addiction, are on chronic opioids, but had cocaine in their urine drug screen. Or they're people who are seeking pain management, but frankly are in pretty early recovery from addiction. Or just people who really have a compelling medical need for opioids, as everybody in this category does, or for some sort of opioid agonist, but they don't have a lot of support. They are homeless, they're in shelters, or else they're just very socially isolated, and they're going to need a lot more support around managing their pain and managing any kind of opioid. So those are the folks who are engaged in that program I told you earlier called Hot Sauce. They're meeting weekly in groups. They're meeting another time per week with one-on-ones with their addictions counselor. They're on, they may be on chronic opioids, but we've been much, much more successful with having them on buprenorphine as an opioid agonist instead. So, and the nice thing about this is that fortunately everybody doesn't hang out at the same level of the pyramid. So to graduate from that level 3 down to level 2, you complete Hot Sauce, which has sort of traditional alcohol and drug program requirements. And to graduate from level 2 down to level 1, we have documented goals that people progress toward. They need to show engagement in behavioral health and meet their behavioral health goals, and that their opioid dosage, if it was above our ceiling limits, has been reduced down to below our ceiling limits. And then just briefly, there's sort of universal precautions around risk with a urine drug screen every 3 months, a pill count every 6 months, reviewing adverse drug reactions every 3 months, and querying our prescription drug monitoring database annually. And this is the floor, and we can sort of ramp up our risk management if needed. And just the last piece, this slide's a little busy and also speaks to my lack of visual skills on PowerPoint, but just to give you a sense of how this unfolds. I mean, that's sort of big conceptual model on the previous slide, but how does this actually work? Well, we have, this is in particular for a new patient coming to our clinic who has self-identified as having chronic pain and has also self-identified as seeking chronic opioid therapy for that pain, and that's screened at intake. And we have an intake coordinator who's not a clinician. She meets with the patient initially, does routine releases of information, consent to treatment, so on and so forth. She also explains to the patient, this is our chronic pain program. And I've kind of written some verbiage for her to use, you know, which is, this is a comprehensive pain management program with a focus on functional improvement and restoration, of which opioids may or may not be a part. And we will do what we can to meet your needs across a broad domain, but our focus is really on improvement of your function. And then also in that agreement is sort of spelling out what we do, but also saying, here's what to expect. These are our ceiling doses. These are our medications we don't use concurrently. We won't be able to provide opioids on the first visit. And frankly, everything's gonna, this is our process, things are gonna go through a committee, and there's again, this is a comprehensive program and not an opioid program. And then the person signs that agreement so that when they get to their first primary care visit, it's pretty clear that they've had informed consent about how our process works. And then we do some risk screening at that intake as well. Screening for opioid risk with the opioid risk tool, which is not a great tool, but it's the best of the ones that's out there. Doing a full PHQ-9 to screen for depression, a full GAD-7 to screen for anxiety disorders, and then a trauma screen for PTSD as well. Coming out of that initial intake appointment, each patient then actually gets 2, sometimes 3 appointments set up. The first is an appointment with their primary care provider. They're also referred to our occupational therapist for really a full functional assessment. What if you know, what's your current functional level? Where do you want to be? What's your community involvement? What's your family involvement? What have you tried around your pain management that has worked? What have you tried that hasn't worked? What do you want to try? So a lot of that information around function, previous trials, goal setting, community and social participation has been done for the primary care provider. And then finally, if any of those behavioral health screens were positive, the person's also set up with one of our psychiatric nurse practitioners. So that information goes to the PCP who sees the patient, does an initial, you know, history and physical to try to do it in the most patient-centered way possible without grilling somebody for details. The PCP reviews outside records, gets a urine drug screen, queries the Oregon Prescription Drug Monitoring Program, and then all of that information from the PCP, from the OT, and from the behavioral health provider all gets funneled to our Controlled Substances Review Committee. And that committee reviews those data and recommends a number of things. They may say, you know, this person's seeking opioids, but for this reason, maybe there's no compelling medical indication, maybe the risks are too high. We're not recommending opioids, but these are the things in the care plan that we can recommend, and you've got a good multidisciplinary team there to put that care plan together. Or they might say, we could do an empiric trial of opioids, and this is the level of care that we think would be appropriate, sort of a hot sauce renew or primary care only, and here are other care plan recommendations. Maybe they need an ergonomic assessment. Maybe they need to see one of our psychiatric providers to have some of their psych medications reevaluated. And we would also make recommendations about buprenorphine at that level as well. I'll just go through these last few quickly so that we can leave plenty of time for questions. But overall, the response is, like most things, is around a B, B+. I don't want to say that everything is perfect. Providers, similar to what Nurit was saying, don't appreciate not having to go at it alone. These are some of their quotes, saying it makes being strict less personal and also enables discussions around larger public health concerns or population concerns around the use of opioids. Providers originally felt, one guy used the term that we were just a juice bar handing out opioids, and felt that they were happy and not having to do that as much anymore. But again, this is sort of provider and not patient-centric, but felt that patients still needed to understand their responsibility more in team management. I think that speaks to the need for some more motivational interviewing training. But overall, appreciate the structure and team support in multiple modalities of treatment. There's perceived decreased burden on the staff, and patient expectations are better managed. Patients, some of them love our groups and find them supportive and helpful, sometimes feel that they're just counting their time so that they can get their prescriptions, and I think that's pretty realistic. And I think there's this intersection as well with patients, people who have a lot of trauma, social isolation, where this kind of structure and particularly lower opioid doses is challenging and makes people fearful and angry. So a few of our lessons learned, I think if we were to do one thing, if any clinic starting out was to do one thing, the benefit of having some guidelines that you all adhere to and a review committee is pretty hard to dispute, and it doesn't take that much resource to do. We're still trying to work through that cognitive dissonance between providers and patients when you're talking about population level data, but the patient's saying, but I'm not that, but that's not me, and that will never be me. We're still also trying to always figure out how best to move our patients, I guess ourselves and our patients, up what I think of as motivation mountain. I think we often talk to patients as if they're halfway up that mountain and they're much lower, and how do we continue to build engagement and motivation. I love our hot sauce program. It's pretty innovative, but I have to say that buprenorphine has really been the game changer in terms of being able to provide safe and responsible opioid agonist therapy. And I think, I think we're sort of finally swinging towards a more stable middle place around, what is pain management. And I like this term a lot, that people do need a healthy opioid system. And a lot of people, at least a lot of our folks, have really unhealthy opioid systems, and they've been ravaged by addiction and trauma and other things over time, and do need medically assisted treatment to help them restore that opioid system. But also, they need to have a strong and person-centered rehabilitative program. And then finally, I think, again, we have good behavioral health resources here, but I think there is this incredibly complex triad of trauma, addictions, and chronic pain that I think we can address at oftentimes 2 out of the 3, but that we haven't as a provider community, both medical and behavioral and social service provider community, haven't figured out how to address all three simultaneously, and I really think that's the work of years to come. And I'll stop there. Thank you.
Well, Rachel and Nurit, thank you for great presentations. It was very helpful to see your journey and also have that sense of honesty that even clinics that are further along in this journey still have a lot of work to do. This is not an easy problem to solve. We have a couple questions, a few questions that came up, and then we'll open up and unmute the lines after we go through these questions in case there's people who want to stay on the call. Like I said, we'll open up the lines until 2 o'clock in case people want to have a more detailed discussion. So one question that surfaced is how do you get renegade providers on board? And you always have the group who's very relieved to have the structure because it's not easy to have these conversations, but it seems like there's always one or two providers who disagrees with the committee, who knows the patient better, who doesn't want to do cookbook medicine. How do you manage that?
Well, I'll say at the Petaluma Health Center, because we are largely a family practice and these patients are a smaller percentage of who we see, that we have not had renegade providers for a really long time. I think also the differences in training have really borne out over the last few years. I think that the consensus building around the policy is really the most important thing, and I think that then ends up becoming an issue of management of the provider. So we leave that to the associate medical director, team director, or chief medical officer, whoever it is that needs to really manage that provider in terms of having them kind of follow the clinical guidelines that we've all agreed to. We haven't really had that issue. We really feel like most of the providers with the information that they have really wanted to decrease and to not do anything. They don't want to follow any sort of art of medicine, quote unquote, in the area of pain management. They really just want to be safe for the patients.
What I would add to that is I think it says a lot for your credibility as a medical director or a CMO when you're doing the work yourself. All of our medical directors, and I still see patients, I mean, not full-time, but at least half-time, and a third of our panels are, like everybody else, are folks with chronic pain. So we're kind of in there struggling with it ourselves. So that if there's a provider who's either saying, I need to prescribe more, or I'm not going to prescribe anything, I think there's the opportunity to just sort of sit down with them and say, well, what are you experiencing? What's going on? Because we're all in this struggle together, and there's unbelievable ambiguity here. This isn't easy. And to use those as discussion opportunities, as learning opportunities for your provider group. Because I think if this is top-down and you're not if you don't have skin in the game yourself as an administrator, these are hard things to, quote-unquote, enforce.
Another question came up about buprenorphine. Are you using it strictly for substance use disorder, or using it for chronic pain, or is there a kind of gray zone? Rachel, you want to take that?
Sure. I mean, so there are off-label indications for bup for chronic pain, but all of our bup prescribers have their DEA waiver, have their X number, and follow all of those guidelines, and use it, have in the chart the diagnosis of opioid use disorder. Now, are all of those bup patients people who have no chronic pain and are just using prescription opioids recreationally or just using heroin? No, I mean probably 80% of them. Well, that's not. I actually don't know the number, but a large number of them do have chronic pain as well, but have significant risk around it. Sometimes it is that you're trying to taper them down off of high-dose opioids, and the impact of that is really severe on the patient. They may get withdrawals and cravings. They may also just say their quality of life is plummeting. And again, that's that's where I sometimes get to that question of, okay, how are we best going to achieve a healthy opioid system? And it may be that converting to buprenorphine allows their opioids receptors to be saturated in a way that's safer for them and safer for the community. Do all of these patients have, would they come up to you and say, yes, I have an opioid use disorder? No, I don't think so. I think, again, that's part of the craziness of this situation and part of the ambiguity. But I don't think it's hard when somebody is on significant dose opioids to make a diagnosis of opioid use disorder in that person. And then you just have to be very gentle and deliberative and iterative in how you talk about the use of those medications, not in a way that's deceptive, but in a way that helps them to build their understanding of not how the pill is helping them, but what the pill is doing to them.
Have either of you, I'm going to go through some of these. Oh, Nurit, any comments before I go to the next question?
Yeah, we are using it mainly for chronic pain patients who we think are having trouble with their current prescription, so it's kind of an overlap area, so kind of a harm reduction strategy. And we would like to expand our use of it, but the difficulty in that is with induction, and if we could have more outside support in induction, then I think we could definitely broaden the number of patients that we're using it with.
Yeah, for the first time I heard an addiction specialist talk about a fentanyl bridge that made the induction almost painless. Have any of you used any induction methods to make it less difficult and less time consuming?
I have not heard of the fentanyl bridges.
Okay, I'll send it around because it's a way to bridge that because of the various receptors. I think fentanyl is either, I'll have to look it up in terms of why it works, so you can have fentanyl on board when you give the first buprenorphine dose and not go into withdrawal, but we'll send that information around. The next question is, do either of you have a pharmacist involved in your pain management team, and if so, what is that role?
Well, we do have pharmacy in-house, and one of the nice things about setting up that pharmacy is that we were able to talk about what are the medications that we have on our pain management guidelines to make sure that the other medications were not there. And then they're very cooperative in terms of they want to be on the same team. So we can't force patients to use our pharmacy. We can just give them that option. But by doing that, and when they choose it, then we really are aligned in terms of refill time and what the medications are and safety of medications. And then that person also sits and meets in with their Project ECHO group and is available for consultation.
The next question is, go ahead.
Oh, I was just going to say we don't have one engaged. And the one thing I did just want to say, sorry, Kelly, just back on the buprenorphine question is, we actually do a whole home inductions for buprenorphine, which works pretty well. And if anybody wanted to, we could share those protocols or things. We don't actually do them here in the clinic, and that's been pretty successful for us.
Great. So if anyone's in particular interested in the buprenorphine resources, either the fentanyl bridge or information from one of these folks, just please email us. You can email me directly at kpifer@chcf.org or go through the CIN website. There's another question related to the complementary medicine. So both of you have been able to add services which are not payable by Medi-Cal. So how do you afford that? And how do you get the funding?
Probably in different ways, sure. We have acupuncture done by family doctors, and we do a medical visit with acupuncture, so that's how we have that covered. And then for other, we don't have a naturopath, but for other services like nutritionists or for physical therapy, for example, if we have that in a group, we continue to have a medical provider, and we just always try to have it be kind of a holistic view of the patient, so we're actually treating them medically in addition to education or to complementary type medicine.
I hate saying, like in Oregon, we actually, naturopaths are credentialed and approved as primary care providers in Oregon. And so we can bill for naturopathic visits. I think it would be, again, Oregon Health Plan also covers acupuncture for specific conditions. We have this above the line, below the line thing. And so for conditions which are above the line, we can bill acupuncture. I think another way to do this, the way we fund our occupational therapy, for instance, because that's somewhat billable, but the amount of authorizations and paperwork you have to, and the limitation of conditions just makes it cost prohibitive to try to bill for it. So when we have our group visits, which are really where the OT is providing a lot of curricular design and support, the primary care provider sits in on those visits, and they're an hour long. And there's enough content. It's a group medical visit appointment. Mm-hmm. So there's enough content within the group, and the provider can see the patient afterward if needed, but enough so that you can bill an individual visit for all 8 people who are in that group. So if ordinarily I'm billing, 3 people in an hour, but all of a sudden in an hour I'm billing 8 people, we use that margin of those extra billable visits in that hour to pay for things like the occupational therapist who's not covered.
Yep. Yeah, we do the same model. The shared medical visit model is, I think, a great model for getting kind of ancillary providers in. And it's a great model because the patients are kind of feeding off of each other in terms of asking questions and getting answers and different examples of what has worked or what hasn't worked.
We have a question coming in about PCP education. A lot of this work is work that primary care providers were not trained in terms of how do you handle a surprising urine drug test, how do you have these hard conversations. A lot of us weren't trained in understanding addiction and the long-term consequences of opioids. So what's your strategy to train PCPs?
Well, so for addiction, we send a lot of folks to dedicated addictions training. It's hard to find in Oregon, so we send a lot of folks to the California Society of Addiction Medicine, which is either in Northern or Southern California. They alternate it each year. It's unbelievable training. We also designed, because the need for addiction training was so strong in Oregon, we designed a day-long certified CME on addictions, pulling from providers from all over the community, and then actually work closely with a pain anesthesiologist to do a pain and addictions module. So I think it's worth, it's so, the availability of training is so low and the need is so high that it sort of stands to reason to invest resources either in sending people out to trainings or to see what you can develop within your own community to provide that training.
Mm-hmm. Yeah, we've been really pleased most recently because we were having providers go to CMEs, or we would do twice a year, we would do a provider CME around pain management. But now that we've been involved with the UC Davis Project ECHO, that has really opened up a lot of doors for us. So in terms of education of a core group of people who then can kind of do a train-the-trainer model, be a resource as well as educators. So they just did a first education related to pearls that they learned from that session. And they learned a lot, and those are folks that actually have been kind of managing and treating this for quite a while. So I think as things develop, it's really nice to have kind of a direct connection with an academic group like UC Davis in order to kind of get that information to the rest of the group.
And there's going to be a great resource available later in the fall. Dr. Corey Waller is a nationally recognized addiction and pain management specialist, and he got an RWJ grant to put around 200 mini lectures. 5 to 8 minutes is about all we have attention span for anymore. 200 lectures on lots of different topics related to addiction and pain management, as well as pathways for treatment. So this will be available later in the fall, and I think it'll be a great resource. So Canal, if you could open up the lines, anyone who wants to stay on the call is welcome to ask questions, or we can unmute everybody. And meanwhile, I think I'll ask one more question, which is how many clinics are just not going to be able to figure out how to get complementary medicine resources in the clinic for financial reasons or availability of practitioners. How important is that? Is that icing on the cake, or do you see that as central?
sorry, Kelly, are you asking us or are you asking the group?
Yeah, I'm asking you. Yeah, Rachel, do you want to take that and then Nurit?
Oh, sure. Well, I mean, again, I sort of just went through the evidence, and particularly for acupuncture, the evidence is decent. I think the evidence for physical therapy is, looking at it is somewhat stronger. But I think that, I mean, I think it's important in that it's another tool to have. I ultimately try to encourage people more to move from passive modalities of pain management like acupuncture, massage, to more active modalities of pain management where they're doing more either physical activity with physical therapy or more mindfulness meditation work and developing those skills. So I think it's again, I think there's good evidence for it, and I use it in particular as if people aren't that motivated around self-management for their pain as an entry point, as for acupuncture as a more passive modality, which then hopefully transitions to more active modality.
Yeah, I really agree with that. Our patients love acupuncture. We have a huge wait for acupuncture, and I think it's mostly because it is a passive modality. And they do feel like it's working for them by and large, but I'm not sure that it gets them as motivated in terms of function for the long term. So I think that the three pillars of, treatment, that there's a medical aspect of treatment, and that may be opioids or other medications. And there's a strong behavioral component of treating chronic pain that I think is maybe even more important than anything else. And that really lies in all of the behavioral management, self-management, really understanding if there's depression, anxiety, trauma, all of those things, and actually moving forward in terms of treating them, and treating them kind of as a team, so that it's not just the medical person who's always making the decisions. And then lastly, in terms of the functional piece, I think that physical therapy is really the best thing. We don't really have that here that we can do right now, and we really want to. So we have a little bit of physical therapy, and we have resources for referral, but it just seems like it's really lacking from our program. And I like that it's an active therapy that patients are going to be kind of engaging in and moving forward.
So this ends the formal part of our webinar. I want to thank our two speakers. You've been fabulous in sharing your journey. The recording for this webinar will be available within a week on our website. If you have any particular questions, you can always email us. The lines are unmuted, so if anyone has a question that, or topic they'd like to bring up for discussion, speak up.
Hi, this is Dr. Jean Marsters calling from Oakland, and I have a question. Can you hear me?
Yeah, yes.
Great. I had a question for the first speaker. I don't know if I'm going to quote you exactly on this, but you talked about sort of evolving your guidelines and your pain guidelines, and including, people in the decisions in evolving the guidelines. Have you guys considered, are you guys using the California Medical Board's recent chronic pain guidelines as a kind of a roadmap yet, or is that something that you're thinking about doing?
We've been looking at that. We've been looking at the Oregon Prescribing Guidelines. We've been looking at guidelines that came from Partnership Health Plan, who's a managed Medi-Cal in our area. And I think that, the most important thing that we're trying to get into our guidelines at this point in terms of expanded decision-making is really having the decision-making, if there's a lot of risks and there's a behavioral health assessment that this is not a good candidate for opioids, then not making that really an option. There's not a reason to then send the person again to primary care to then renegotiate whether or not this is going to happen. So kind of having a different bar in terms of behavioral health and medical working together is kind of where we're moving.
And this is Kelly Piper. Having been in clinic developing guidelines before, the previous medical board guidelines were just not that helpful. The new ones that came out, I think, are very consistent with the Petaluma Health Center guidelines, with Oregon. They're much better and a much better pathway for clinics who are just starting this process. Any other questions?
I would say that all of those guidelines are really similar to each other. Actually, they really are, talk about all of the same things in terms of harm reduction and kind of the things that patients need to have. So any one of those is fine. I think it's really just how you play them out and who gets to make the decisions. That's really the key.
Other questions?
I saw one of the photos in the presentation being a yoga demonstration, I think. Is that also part of the program, either in Petaluma or in Portland?
I'm sorry, I couldn't quite understand. You saw.
So in the slides, there was a yoga class or demonstration going on. I'm curious if that was also part of the integrative medicine in one of the sites.
Yeah, we do have a community fitness program that includes yoga. It also includes things like Zumba, so it's kind of all across the map. So we try to make it so that there are kind of more gentle, and in fact, they were running a chair yoga class in addition. We also run the mindful-based stress reduction course. And we try to keep the community fitness program is actually open beyond our patients, and we just try to make it a break even to keep it going as best we can, and that's been successful, which is great.
Thank you.
Any other questions or comments?
You mentioned the ECHO program at Davis. I think that's fairly new. Is that like a weekly conference with a presentation on it?
Yeah. I should have actually given more content on that. I'm not sure how many people are aware of it. So that started through the University of New Mexico, and by having consultants that had a weekly conference, kind of like essentially teleconference with clinic sites, outlying clinic sites, they were able to give them a lot of decision support around chronic pain, around treating hepatitis C, and it really grew and grew. So UC Davis took this on, and we were able to sign on to it through Partnership Health Plan. And we have it's essentially a weekly hour and a half. They go through some didactic session initially, and then you bring in cases for them. So you have a difficult patient, and you talk through it, and it's great. It kind of empowers the health center or the whatever the site is to kind of make that team, and then for that team to feel quite knowledgeable. But then it continues to give them a resource for consultation.
And so UC Davis is interested in expanding to new sites. So if anyone on the phone is interested in joining Project ECHO, you can contact us, and we'll let you know what that would involve.
On their side, they also are multidisciplinary. So the people, there's a pain specialist, there's addiction specialist. So they have the gamut of people as well, which is great.
Okay, other questions?
I had another question, which I guess it has to do with sort of evolving all of the people who work at the clinic more towards an innovative and comprehensive way of managing chronic pain, because everybody who works at our clinic sort of has their own experience of it. It includes the front desk staff, because they get calls and patients bugging them, and people who've missed appointments, and people asking for early refills. So we've got the whole sort of the people dealing with sort of the intake end, and then we have the primary care providers who are stretched thin time-wise, and the nursing staff and the MAs that are all supporting them. And it kind of feels like a lot of what happens right now is just everybody kind of is in their own world of experiencing chronic pain. And I think that I'm wondering how you evolve people into kind of all getting on the same page and adopting sort of a more comprehensive, because I feel like our clinic just kind of does, like we put out fires here and there, but it doesn't feel to me like there's been any kind of a meaningful evolution.
Yeah. This is Nurit talking. So I feel like there has been a great evolution, but yet I still feel exactly what you're saying, that I would love it to be, that much more advanced. So I think that empowering the team in terms of the decision making and making the team smaller, so really just a pod that is seeing the patients from front office all the way to the back, and kind of devoting the time and resource to meeting around that, and then kind of using some of the innovation techniques that people kind of talk about the journey of that patient and figure out what are the pain points, like where is this really a difficult process and why, and what are my most important things that I want to solve. It really starts to empower the staff. We found in 2005 when we did this, and we really asked the staff, like, what do you think? And they had so many great suggestions about how they thought things could improve. So I find that the staff tends to know a lot around these patients, maybe even more than the providers in a lot of ways. And so they really were very clear on, like, we need to do it this way and not that way. Let's all be consistent. They were really ready to be consistent. It was more on the provider side and we said, hey, everyone's ready to be consistent and to support you, so you're ready also, and then they said yes. So I think that it's really kind of in the way that there's a meeting is the most important. So not just having the providers meet with providers and these people meet with those people, but really meeting all together in a group that's not too large, and kind of talking about the reality, so a call to action, and then moving forward with some kind of consensus building through innovation techniques and brainstorming. Then I found that to be the most successful in terms of, okay, now we're going to take that back and we're going to redo the protocol, we're going to change this and that, and this is what we agreed on, and everyone kind of moves forward.
I have a couple of thoughts about that. I think so I was just thinking first about provider education. You have to understand what the problem is, and we often ask ourselves, sort of with pain, well, what's wrong with you? And I think the more we know about the overlap between pain and addiction and trauma, is it's not what's wrong with you, it's what happened to you. And as we've done more training with providers around the neurobiology of pain and the neurobiology of addiction, which are very closely related, and the developmental biology, particularly with people who've experienced early childhood trauma and how that leads to expressions of pain and addiction, which are very closely interrelated, that really radically changes the mindset of, you're driving me crazy, to or this is frustrating, to, okay, I actually can understand what's driving these behaviors, which are both maladaptive and actually adaptive mechanisms, and how can we work with that? So I think that's one way of starting to help to understand what the root causes of and the lived experiences are that produce that behavior on the provider side. I think we've done a fair bit of that. A place where we need to do more is a full trauma-informed care assessment across our organization. Because again, I have a hard time picking apart pain and trauma and addiction. They all stem from the same place, and they actually all look the same kind of neurobiologically. So we're early in these stages, but I think that will help us from a sort of full organizational standpoint to better attune ourselves to how to be sensitive to, as well as not just responsive to, but actually have particular skills around working with folks who've experienced a lot of trauma. And that I can try to find, I can send to Kelly. There's some really good national resources on that, which a multidisciplinary group here at Central City is starting to employ. We're not making it up. I mean, we're not developing it ourselves.
Right. If you Google trauma-informed care, you'll see some great resources. It's really changing how people think about working with folks with all of the impacts of poverty. We got a great question just came in. So how have you collaborated with other providers, with health plans, with emergency departments to try and have a strategy that's community-wide as opposed to just within your clinic? And Nurit, why don't you tackle this, and then Rachel?
Nurit, did you want to go first?
I'm sorry, I'm here. Yeah, go ahead. I'm sorry, can you repeat that question one more time? I just had that clinical issue come into my office.
Rachel, go ahead and tackle it, and then I'll tell Nurit.
Sure. So the question was about sort of a community-wide response. So we don't have ACOs here, we have CCOs, and so everybody's sort of organizing and doing different things. But there are two key efforts, I think, that are worth noting, which are happening through our CCOs. One is we don't have prescribing guidelines by law the way the state of Washington does. But between our CCOs and our hospital systems and public health departments, actually our tri-county health officer is leading an initiative around community prescribing guidelines, which is terrific if everybody's prescribing in the same way. And that includes not just a punitive prescribing approach, I think, but also they're also incorporating what are the other things that are needed in terms of behavioral health and self-management for pain. So that's one effort. And I'm thrilled that what the Tri-County Health Officer is also doing is a sort of public awareness program and starting to help the community understand what the risks and benefits of opioids are. And that's in its nascent stages. But I'm pleased that they're taking kind of a broad public health and education approach in addition to, okay, providers and ED departments and dentists and surgeons, this is how we all want you to prescribe.
If you're not speaking, if you can mute your line, we're getting a lot of background noise.
What's happening on a community level in Sonoma County, interestingly, there have been other counties in Northern California, like Marin County, for example, where the public health officer did create an initiative in addition to Solano County. So Sonoma County is starting that now. We have a Committee for Healthcare Improvement. That group is convening all the stakeholders and trying to essentially do the same things that Rachel's talking about, so safe prescribing guidelines, a education and awareness plan to the public, which I have told them I think is really crucially important, and then really looping in more and more stakeholders, and kind of figuring out how are we going to get, which group are we going to get through first? Are we going to go to all the emergency rooms first? Are we going to go here? Where are we going to go, and how are we going to get everybody connected? There's a separate effort going on related to preventing neonatal abstinence syndrome, which is higher in our county than in other counties in California, and that has to do with kind of a younger push of public awareness, and that's being done also through the county, through the Maternal, Child, and Adolescent Health Council. So they already have a 5-year plan where they've identified stakeholders, and they're starting to move forward through a public awareness campaign as well. So I think there's some good county effort happening in Sonoma County now. It's kind of also in its beginning stages, but there's kind of a groundswell, which is exciting about it. I think the biggest thing that we're seeing for Northern California is through Partnership Health Plan and their move forward in terms of safe prescribing guidelines and requirement really of treatment authorization requests and weaning plans for patients who are on high doses of opioids. That is playing itself out currently. There's a little bit of it started about 6 months ago, and we just entered the second phase, so very exciting to see that happen as well. That really does give the providers support on the health plan side and kind of moving forward, so we've been really pleased with it.
Great. Any other questions or comments?
I had two other questions. One is just the general question that it would be lovely if you guys could post some, resources and tools, which could include some of the things you've mentioned, but also, if any of you guys have things like weaning plans or other sort of practical tools that you're moving to implement, it would be nice if we could get them off the internet and then, pass them around and consider implementing them in our healthcare systems. Because I'm always looking for resources to share with other docs, and that can help sort of give people ideas for ways that we can change and evolve. So that's just kind of a request. The question I have, though, is experience with buprenorphine for these patients that are, have come to the clinic because they're in pain. They've had aberrant behaviors, not handling their opiate prescriptions well, or their tox screens are coming in positive or whatever. What do you think, what's the best system for inducing them? And the other thing is, how is it following them in a primary care setting? Are they easy to manage? Does it take a while for them to settle down? What's the experience with that?
Rachel, do you want to answer from your specialty initially?
It looks like we lost her. Nurit, do you want to tackle that?
Oh, yeah. You know, I can. So I'm not one of the buprenorphine prescribers, so I can tell you a little bit secondhand. It can be extremely difficult to induce those patients. It's pretty time-consuming for those providers. And what happens is that they tend to get inundated with requests, and they're really wanting, they're wanting to kind of figure out a better way for all of us to do it. So it's initially time-consuming. It's time-consuming because they have to get authorization from the state. So that's a state Medi-Cal medication and not a partnership health plan medication. So that initial piece, I think, is very time-consuming. But I will say that afterwards, those patients stabilize really, really well. And in fact, I would say that they are probably more stable than all of our other chronic pain patients. I do mean that honestly. They have additional expertise kind of in the sense of thinking if they have to go in for surgery or what's going to happen. They've had to transition some patients off of it. But for the majority of patients that they've been covering on it, they've done well. We have patients here who we've maintained on it essentially, so we haven't weaned it off. We've had some really long time difficult patients that have an overlay of chronic pain and previous addictions. We had a few that requested to be tapered off, and they actually ended up doing really poorly. So so we've been really careful in making those decisions with the patients more recently. So I'd say it's a lot of initial work, and that's kind of why we get into this conversation of having help with inductions. But I think that the maintenance piece of it is not nearly as difficult.
Sorry, guys. I had myself on. I was responsibly trying to be on mute and had not unmuted myself. I was just talking away. Anyway, sorry.
Oh, do you want to talk about the induction as firsthand? Yeah. I was just saying I'm talking about it secondhand because I'm not one of the buprenorphine prescribers.
Yeah. No, yeah, I could hear you. I was just talking to myself. So yeah, so as I mentioned earlier, we do home inductions. So we give people pretty specific instructions of don't use for this long, don't take, don't use heroin, don't use opiates. And we've done urine drug screens in advance, which is not perfect, but at least so we have a sense of knowing if they're using alcohol or benzos or not. And we don't induce them at home. We don't induce them at all if they have urine drug screens positive for alcohol or benzodiazepines. So the home inductions, as I said, generally go pretty well. I mean, we're available, we're on call, and I don't get that many calls about it. I think, again, the tricky thing with bup is it's not the medicine. I mean, it's actually not that trickier than insulin. It's providing the structured support around, around all the other things that come along with addiction, triggers, cravings, their social environments, which might give rise to triggers in particular. So if people, it's partly a function of the organization that I work in, but we have a pretty structured addictions program integrated into our primary care clinic for our buprenorphine patients. Sometimes that's hot sauce if they have a lot of pain management issues, but we also just have straight addictions groups, a straight addictions program within the primary care setting that's run by we have 2, soon to be 3 alcohol and drug counselors here in the clinic. And so they've done an initial assessment with the patient before the induction happens. And then the patients actually start coming to groups twice a week generally before they even get induced. So they've got the sort of traditional A&D group setting, and then they have their counselor that they're able to reach out to. Because what we find more is it's sort of all the other complex social things around substance use disorder are trickier than the medication itself. And so if you can't do that in-house, being able to partner with an addictions treatment agency kind of in your neighborhood and build that kind of medical neighborhood where maybe they could do some of that induction in alcohol, or you could do the induction and they could do the alcohol and drug treatment. And then, you know, if things aren't going well with your patient after they've graduated from treatment, you can always call up the addictions provider at that site or do a warm handoff back to them. Because I really think it's the treatment support is the key more than just the, you know, the trickiness of the medication itself.
And this is Kelly Pfeiffer. I have an ex-license and I've done buprenorphine, and I would echo what Nurit said, that it's the transformation of very unstable patients to stable patients is remarkable. They get out of constantly being in semi-withdrawal and constantly popping more pills, running out of pills. It's pretty amazing. And the two solutions that I've seen to make induction easier, one is in San Francisco. They have an induction clinic, so you can send people there. They get induced, stabilize them back to the PCP with the goal of getting more PCPs to be willing to get buprenorphine licenses for maintenance, which is much easier than induction. In fact, as we've said, often much easier than managing the patient before buprenorphine. The second is that in other health homes in other states, they're using nurse care managers with the idea that the nurse care manager would have a panel of buprenorphine patients and would do all the education and managing through the induction, even though it's the physician who's actually prescribing. The nurse care manager, as a team member, does most of the work. And then finally, the fentanyl bridge option I'm intrigued by, and I think we'll have Dr. Waller, as he builds up his training website, and that will be included in it. And if anyone's interested in his PowerPoint, just email me. Well, we're at the end of time. Go ahead.
Oh, I'm sorry. I just wanted, there was someone who asked for resources, like do you have specific resources? And I want to, again, point you to the Oregon Prescribing Guidelines, because it is one of the most excellent, you can make it into a booklet and give it to your providers. And it's like 60 pages of information, including talking tips with patients, weaning plans, reading urine drug screens. I mean, it really is like the best that I have seen in terms of all the different screening tools you can use, and it's just really chock full of information. So I really would encourage taking a look at it. You can easily find it online. You can print it out in color. You can incorporate it into your own policy. That's what we're doing.
Well, Nurit and Rachel, thanks. Go ahead. Last comment, and then we'll need to close up.
I just had a quick question. I had a group of doctors here who were curious as if they could get these slides. They wanted to review a few more things. Would they come in an email?
Yeah, of course. The slides and the recordings will be available on the website in a week, but if you want them right now, you could email me, kpfeifer@chcf.org, or the email address is on the PowerPoint.
Excellent. Thank you.
Well, great. Again, Nurit and Rachel, thank you for your expertise, and it was a great presentation and a good discussion. And again, we'll have a second webinar that will be focused on health plans who've taken a community regional approach to the problem. So I think, it'll be interest to a broad audience. And then that will be in May, and then later we'll have one that's focused on residency clinics. Just stay in touch with us and make sure you're abreast of all these things we're working on. Please go to CHCF website and then go to California Improvement Network and sign on, and that way you'll be informed of everything that's going on. And we do not spam you. We make sure that you select what you want to hear about. Well, thank you again, and we'll close. Have a great afternoon.